on the sixth nerve, and that's what causes the paresis of the sixth nerve, which causes the cranial nerve 6 palsy. So this is the reason why. So if let's say you have a patient in your chair, whether it's new or a previous patient is the first time that you're seeing bilateral disc edema, the first thing you want to do that you can do as an optometrist is check the blood pressure, make sure it's not malignant hypertension. Ask the patients, see if they fit the demographics. Is it your 30-year-old fertile female that's obese? Has the patient been on any kind of medications that can cause papilledema? You want to rule everything out. But you obviously want to refer out because you have to cover your own tush for neuroimaging and lumbar puncture. But these are just things to look out for right away and not just think, oh, it's brain tumor or it's papilledema. There could be other factors going into there. But the only factor remaining is high opening pressure, so that's what diagnoses PTC. So with the lumbar puncture, so assuming that the MRI is clean, they'll do a lumbar puncture. They do it for either testing purposes or for actual therapeutic purposes. So you evaluate the cerebrospinal fluid between the L2 and S2, because their lumbar cistern are the largest area of the subarachnoid space, so that's the easiest to get to. So they extract it there, and that's how they analyze the cerebrospinal fluid. They check everything, including the pressure, to make the diagnosis. So the pressure seems to be lower when you're laying on your side as opposed to sitting up, because against gravity it's going to be higher. So these are just some normal ranges, some numbers there. Don't really expect anybody to memorize that. Normal pressure for children and adults, obviously people over the age of 8, is anywhere from 10 to 100 millimeters of water. Kids a little bit less. Actually, kids from 90 to 180. And obviously 200 to 300 when you're sitting up, because like I said, you're going against gravity. You also can analyze the white blood cells in the cerebrospinal fluid. In adults, it's up to 5 white blood cells per millimeters cubed. In newborns, it's up to 20. As newborns, they still have their thymus, so their immune system is obviously more active, and the white blood cell count is higher. So, like I said, the protein levels, they're really low, and it's not like in plasma where they're really high in cerebrospinal fluid, they're low, but any kind of elevated protein could mean, something's going on. There's either some kind of infection, meningitis, anything that can be raising up the proteins in the cerebrospinal fluid. The color of it is supposed to be crystal clear. Any kind of discoloration, as you know, that can also indicate a hemorrhage or an infection. So what are some common medications and different things that you can take that can cause? There's a whole laundry list, honestly, too much to fit on this slide. So I just picked out the most common ones, and obviously if you want to look at more, you can always Google. But the main common medication that we all come across as eye doctors, the tetracyclines, the birth controls, the vitamin A, any excess in vitamin A can cause papilledema. Starting or withdrawing from corticosteroid use. Nalidixic acid, which is a synthetic quinolone antibiotic, an oral antibiotic, and growth hormone, amongst the big list that they have, but these are just some of them to look out for.
Could you go back on slide for a second?
Yeah, sure.
I was just looking at the third bullet at the top there, elevated protein levels.
Yes.
MS,
No problem. Am I going at a good pace, guys? Am I talking too fast, too slow?
Okay.
Thank you, guys. So treatment and management of PTC. Obviously, the diuretics, the Diamox or furosemide. The doctor is going to encourage weight loss. You have to, if you're 20% over the ideal body weight, that's what they're going to encourage. Stop whatever the agent, if it is a medicine that they're taking that's causing it, you want to stop that, obviously. Optic nerve decompression surgery, if, like I said, nothing is helping, the medication is not helping, the dieting is not helping, and the papilledema is getting worse, you obviously want to do something so the patient doesn't lose their vision. Shunt replacement surgery, which we'll talk about in a little bit, and you obviously want to co-manage with the neurologist or neuro-ophthalmologist. And just follow up monthly with DFEs, check vision, check the visual fields, and so forth. So like I said, the most common treatment, surgical treatment for papilledema or PTC is the shunt placement. Both of them, like I said, either the shunt placement or the optic nerve sheath fenestration, which is like really like a incision of the sheath of the optic nerve, which lets it to breathe, kind of opens it up a little bit. But you know, it's usually the last step if when everything else fails. Kind of like glaucoma, you put them all drops, Diamox, nothing helps, then you gotta do a trab or whatnot. So with the shunt placement, like I said, the lumboperitoneal or the ventriculoperitoneal is the ones that they commonly use. There's no risk of postoperative vision loss, which is nice. However, there's a high risk of the shunt clogging, and you have to make another revision. So, like blebs, they either work well or they don't work out at all. I have a lot of experience just co-managing with Dr. Stanley Burke. They work great lowering your pressure, but then there's some complication. The patient starts to fibrosis, scar down, you get elevated pressure. Or if, let's say, you're using an express shunt, that little tube can get clogged with this fibrin, and you got to yag it, you got just to lower pressure. There's always complications with the tube or kind of system. The other alternative is the optic nerve sheath fenestration. So it creates you create like a little window flap on the optic nerve sheath. This allows the cerebrospinal fluid to now flow out of the optic nerve sheath. And it can be used for any cause of increased intracranial pressure. It's safe for pregnant women, but there is a 1% chance that there could be permanent vision loss after the procedure. So these are just going over some personal cases of mine. This is actually when I was doing my residency at the Veterans Hospital, my attending's daughter. This is a case for my attending's daughter. So I mean, I worked with her and also saw the daughter at the same time. So her complaint was, Mom, I'm having really bad headaches. So she's 22 years old. Like I said, this is in 2013, so I don't know what the status is now. She's a 22-year-old white female. She was previously diagnosed with tuberous sclerosis, which is a genetic disease that causes a lot of skin abnormalities, and it can also cause benign tumors over a lot of organs, such as the lungs, the brains, the kidneys, the heart, which obviously can be a problem. Even though it's benign, it can cause problems with the organs. She has a history of a subendymal giant cell carcinoma, SEGA. I like to use that. Reminds me of the console. And she had a history of a right internal carotid aneurysm, status like pipeline stent, so she had a stent put in, and she was on Plavix, 75 milligrams, and a full aspirin. So I dilated the eyes and noticed that, I'd say some mild papilledema, probably worse a little bit in the left eye than the right. So, like I said, it's always bilateral, but it can be asymmetric. So some people are like, oh, maybe it's monoculous. Yeah, if you look closer, it's usually both eyes, not one. So we looked at that. So she was sent for a stat CT scan because she's known to have a brain tumor. So she maybe it got bigger, so she wanted to see what's going on. There was no change in the tumor size, status quo. The stent appeared intact. No treatment was indicated at this time. So we said, look, everything looks, I'm not seeing any difference, so we're gonna just watch it for now. So come August, she says the headaches are getting worse. She's complaining to her mom, the headaches are getting worse. And now she's getting onset diplopia at distance. So her eyes either turning in each eye occasionally. She actually said, she was like, I was on a cruise with her and I just saw her eye was popping in, and she was like, what the hell's going on? So we dilated the eyes again. And now, as you can see, now it's getting a lot worse. So this is the fully developed papilledema. Visual field's not too bad, right? You usually expect the typical textbook, large blind spot. In her case, it didn't look so bad. There's a few isolated mispoints, but nothing really pathognomonic for the papilledema. So before I get into her MRI, I just want to show you guys what a normal MRI looks like at the brain, just so we can see the difference and appreciate the difference. So here you see it's like a bird eyes view, axial cut. So those are the lateral ventricles. Okay, there's the anterior horns and the dorsal horns. So you'll see her MRIs now. Okay, so here's the T1 and T2 with contrast. You can clearly see here that here is her brain tumor. And you see it's impinging on the lateral ventricles, which is causing dilation of the ventricles, which is what? Hydrocephalus. So there was an increase in the SEGA size. There's a little bit of an increase and enlargement of the lateral ventricles. Here's like a more dorsal side from the back. So she was put on IV prednisone initially when she was hospitalized, and then oral prednisone, 100 milligrams for 7 days, and then tapered off, obviously. She was also put on Diamox, 250 milligrams QID, and she had a consultation with the neurosurgeon. The neurosurgeon said he wasn't going to do anything because she was still on Plavix, and he wanted to hold off for now. So she saw a neuro-oncologist, and he decided to put her on Afinitor, which is a chemo agent that shrinks the brain tumor size. So at the 1 week follow-up, patient's headaches and diplopia resolved. The Diamox and prednisone eventually was discontinued. The first MRI after the Afinitor treatment showed there was a slight reduction in size, so it did help a little bit, reducing the tumor size, and improved appearance of the lateral ventricles. So at that point, like I said, I was finishing up my residency, and she was continued on Afinitor and baby aspirin. I don't know how long, but they said at some point they would probably want to do a neuroendopore surgery to remove the mass at a later time. So I don't know what the update is now, but that's how I last left it when I finished my residency. It's an interesting case, nonetheless, right? Yeah.
Why does the prednisone help the tumors?
Well, I mean, any kind of, it's part of the chemo agent. My dad had lymphoma, and it was one of the chemo agents because it's inflammatory, so it's to shrink. It probably acts in terms of shrinking the tumor size. Anything, prednisone is like the miracle drug. It works for everything, clearly. So I did, in September, a month later, I examined her again, and look at the optic nerves, back down to normal. So thankfully, there's no atrophy, which you can see pallor and stuff, so she did pretty well. I don't know what she's doing now, but hopefully she's in good hands. So now that we discussed papilledema, now we want to discuss when it's not papilledema. So when the bilateral disc edema is not caused by increased intracoronary pressure, one must always consider pseudopapilledema or bilateral disc edema secondary to systemic disease such as hypertension or diabetes, which I'm going to discuss those two because we commonly deal with that in our office when patients are hypertensive or diabetic. The two common congenital disc anomalies are the congenitally full disc, as I discussed, and the bilateral optic disc drusen, and then the disc edema that happens from hypertension and diabetes. I'll also go over that as well. So this looks like a sole nerve. I mean, I don't blame anybody to take a second, third look at it. I mean, it looks elevated. The disc margin's a little bit blurred, but it's a densely rich packed optic nerve. There's a lot of ganglion cell and axons that's converged there. Probably a small disc, probably a hyperope. Because as you see, the hyperopes have smaller eyeballs, so everything is more packed, whereas myopes, everything is longer, and you get that bigger cup, tilted nerve, because everything is more stretched out. Patients are asymptomatic, they don't have the headaches, nausea, ringing in the ears, nothing like that. So I've seen them, I really see them a lot in children, and I don't really hit the panic button. But this is just so you know, I'm sure you guys see it all the time. Sometimes you don't even see a cup and it just looks so elevated, but it is pseudo-papilledema, it's not true papilledema. Happens more commonly in Caucasians. It's more commonly bilateral than unilateral. Oh, actually, I'm sorry, I just skipped over. This is bilateral disc drusen now, so we did the congenitally full disc. So in disc drusen, more commonly bilateral. The drusen are hyaline calcific bodies that are buried underneath the optic nerve. So these drusen push the optic nerve, the NFL, anteriorly, gives it that lobulate appearance, or it seems like it's elevated. The same drusen, like I said, because they're like little crystal stones in there, the drusen, as they push anteriorly, they can actually nick the capillaries surrounding the optic nerve, which can cause a hemorrhage. So you see what looks like an elevated nerve, and then you also see little splinter hemes around, and you're like, scratching your head, like, what could it be? So some patients, it's not uncommon to have a visual field defect from optic nerve drusen, because like I said, it is piercing into the NFL, and it can cause a visual field defect. So I had a case actually when I was a resident at the VA. I had a 27-year-old vet serving during the Afghan-Iraqi war. He went to Walmart and he saw an optometrist there, and the optometrist says, "I think you may have papilledema." Scared the bejesus out of him. So he came to see me, and he says, "Listen, I've been having a headache for a month, and then my Walmart optometrist said that I had papilledema." And I looked it up, I Googled it, and it says, brain tumor, and I'm freaking out over here. What can you tell me, doc? So I was like, all right, let me take a look at myself. I took my history. Everything seems pretty. He had some sinus congestion as well, which also could exacerbate headaches. Someone who has sinus disease can also have very bad headaches. The only medication he was on was Seroquel for anxiety. Visual acuity is uncorrected, is 20/40 in both eyes. Everything else tested out pretty pretty normal. Color vision was fine too. He did notice a slight dimming in the right eye in terms of the contrast with the red cap desaturation test. I refracted him to 20/20, so just a mild myope. IOP was fine, the anterior segment was unremarkable. I did a 24-2C to fast, and it was reliable, just a few isolated missed points, nothing serious. But those were his nerves. So you can see that it's more sectoral. The elevated is superiorly here in the left eye. You can see it's lobulated and it's protruding forward. But nothing really else going on. I mean, drusen's there. Fortunately, there at the VA also had a B-scan. So B-scans come very helpful when you want to rule out. If you're thinking, oh, it looks like, you know, optic disc drusen, let me verify, confirm, just like when we verify things with OCT. So, surely enough, bam. How classic is that? You can clearly see that it hyperfluoresces. That's the drusen there, on the optic nerve drusen there. So I told him, don't worry, it's optic nerve head drusen. Nothing you can do about it, but you don't have a brain tumor or anything like that. So he was very relieved and grateful. So that's why I said, you know, it's just, you got to be reserve of caution. You want to do the best you can. You can send that out as rule out papilledema, but really the correct term is bilateral disc edema. They got to find out otherwise when you send them out.
Would that show on an OCT as well?
You may have nerve fiber layer defects around the optic nerve, like it's going to come up a thinning, but that's from the drusen itself. But
You wouldn't see the drusen.
You won't see the drusen, no. Unless you use like maybe an autofluorescence. I mean, I don't really use it that much, as I know I should be using it, but I don't really use that option so much. So now we're going to go into malignant hypertensive optic neuropathy and diabetic papillopathy, which can also manifest like bilateral disc edema. So someone who has malignant hypertensive optic neuropathy, the blood pressure systolic is over 200 and the diastolic is over 140. So now you know it's out the door to the emergency room right away. It's more common in African Americans, more prevalent in women than men. And like I said, it's a stat referral, so you send that right away. So you can see here, and even this picture, obviously this is a stage 4 because there's a macular star, but you can see how the optic nerve looks elevated and swollen. So what you can see with obviously malignant hypertension is you'll have your retinal deflame-shaped hemes, Cotton-Wool spots, congested retinal veins, changes to the vasculature, probably AV nicking as well, shunt vessels. But the really clinical pathognomonic signs are these focal intraretinal periarterial transudates, which are pathognomonic for, so you're thinking like, oh, transudates, exudates, what's the difference? So transudates are fluid that leaks out of the capillaries from forced pressure, whereas exudates are this fluid that leaks out from just inflamed capillary walls or damage to the pericytes, which are the little cells within the lumen of the capillaries, which gets damaged, as you know, from diabetes. So that leaks out there, but this is strictly from the hypertension. So when you see that, they kind of look like exudates. I couldn't really find a good picture. They kind of look like little exudates, but there's that's just one of the things to look out for as well. So when you have malignant hypertension, you have a breakdown in the autoregulatory system and breakdown of the blood-retinal barrier. So just like when autoregulation is like when your blood pressure goes up, there's such a high flow to the cerebrum that you want to, the lumen will start to constrict. The same thing when your blood pressure drops, the blood vessels also expand when your blood pressure drops. So once it hits a certain case, then there's nothing going on. So you just have this high velocity flow and leakage that happens from just the damage from the capillaries. So what you can see in malignant hypertension are these L-Schnick spots, which is not to be confused with L-Schnick pearls, which is what you see after cataract surgery on the anterior capsule, on the rectus probably too. And Seeger streaks, which are these like black linear streaks. And obviously, stage 4, you'll see the disc edema, bilateral disc edema with the macular star present. So here are just some pictures. These are the L-Schnick spots. When I looked up the focal intraretinal the spots that I mentioned here, the periarticular transudate, so I looked them up on Google to find a good picture. They pretty much look similar to that, so I didn't want to confuse anybody, but probably you can find a good picture somewhere in a textbook. So this is what the L-Schnick spots look like, and the Seeger streaks, and obviously they hyperfluoresce on FA. So when you have the management for malignant hypertension is obviously when you see that someone has malignant hypertension, you refer them to the emergency room right away. At the emergency room, they will start to lower their blood pressure gradually, not too much because you don't want to throw the system out of whack where you're not getting enough blood to the brain. So the mean arterial pressure should be lowered no more than 20% the first hour of treatment. So they're going to reduce it very, very slowly, not fast. So this patient will be in ICU. If it's really that bad, they're going to actually watch him very closely. So in diabetic papillopathy, so in your diabetic patients, it can be seen more in type 1 diabetes. It's actually, the literature says it's actually a form of NAION. Because just as we know that diabetes is an ischemic disease, there's ischemia to the optic nerve head which causes edema. So when there's edema, the optic nerve gets inflamed as well. When it becomes inflamed, like I said, all the axons become more packed and can make you more at risk for an NAION. The other time you see NAION is if someone has a congenitally full disc and you want to tell the older guy to lay off the happy blue pills. But with this, there's no constriction of visual field, there's no decrease in vision unless someone has CSME that's affecting the vision. So but if you do have the diabetic papillary, the bilateral disc edema does resolve. So the prognosis is good, 2 to 10 months usually. Obviously the patient's blood sugar has to be under control. Yeah, so with this you may see a large blind spot, kind of like in PTC as well. I mentioned the NAION. If you have it, you're more prone to developing CSME in the future according to the studies. And it does resolve 2 to 10 months with no significant impact on the vision. So obviously as your optometrist, you want to emphasize the importance of keeping the blood sugar under control. So here are just some clinical pearls just to take home with you or to the office. So if you see bilateral disc edema, first thing you do, if you do have a BP cuff, if you're in a setting where you have BP, check the blood pressure. Probe the patients. Do you have any bad headaches? Do you have ringing of the ears? Do you have any weird phenomena happening with your vision? Are there any kind of medication that you think can be causing papilledema? They fit the criteria demographically. And then you, like I said, if you have a B scan, you can do a B scan to rule out optic nerve head drusen. And then you're gonna obviously refer out. You know, I mean, it's pretty much what we do anyway. We're not like superheroes over here, but you know, if you have a right set of thinking, you also look good to the attending physician, and it's also you're participating and doing the right thing by the patient as well. So it's just overall good care from start to finish. So you want to refer out for the MRI, MRV with the lumbar puncture and CSF analysis, and obviously co-manage with the healthcare providers. And that's it. I don't know if I did an hour or not, I'm sorry.